Great. Thank you. It is a pleasure and an honor to be here. I want to thank all of the supporters and sponsors for giving me the opportunity to spend a little time with all of you today. And I want to thank Rick in particular, who for several months now, he and I have been working on putting this together and making sure that we present to you some things that are of most importance. In today's world, really in the last year and a half or so since the tragic deaths of Kate Spade and Anthony Bourdain, suicide and suicide prevention have been more in the public eye than really ever before, even more than when Robin Williams died by suicide. And we know that there are many, many people in our country that are living with mental illnesses. I'll talk about that in a minute, that are living with thoughts of suicide. And tragically, we have many that are dying by suicide. So in today's presentation, I hope to give you a very basic and broad overview of some things relative to suicide in the workplace, and reaffirm for you what you probably already know, which is when a suicide occurs in a workplace, or when a workplace is identified somebody who is at risk of suicide or having suicidal thoughts, it becomes very difficult for the workplace. The direct managers, the leadership, for people that they might be supervising, and for the individual themselves at work and returning to work. This is a major issue that is addressed in the National Strategy for Suicide Prevention, and hopefully will be by more and more businesses as we go forward, because as you heard at the opening, suicide is the 10th leading cause of death in our country. It is a leading cause of death for those that are in the workforce age. This afternoon, I'm going to present a quick look at some of the numbers and the impact that depression has on the workplace, talk about what we know about suicide being preventable, and specifically how it can be prevented in the workplace and what workplaces can do to address suicide, and then finally end with how my organization addresses this topic. Moving on to a quick look at some of the numbers, and for some you may be more familiar with these than others. Mental illness is common. It isn't normal, but it is common. 1 in 5 will experience a mental illness at some time in their lifetime. About 1 in 4 adults will suffer with major depressive disorder at some point in the year. 44 million adults will have some type of mental illness, whether that is depression or bipolar disorder, an anxiety disorder, or some of the other illnesses that are diagnosed. Many live with serious and persistent mental illness, which is SMI, serious and persistent mental illnesses. These are very significant long-term chronic illnesses. About half of these illnesses begin very early on in life, and they really exacerbate after high school in the early 20s. We also know that untreated depression, in particular, can be one of the underlying causes of suicide. Somewhere between 40 and 60% of those people who die by suicide have depression at the time of their death. So about 50%. Some studies will say up to 60%. Other illnesses that are closely related to death by suicide include bipolar disorder, what some people might think of as manic depression, schizophrenia, which is a smaller number of people in our country and in the world, and still people that are involved in the workplace, and anxiety disorders. Mental illnesses involve the entire body. It is not something that just happens in the brain. Somebody struggling with mental illness might feel it physically in terms of their energy level, their ability to concentrate, their emotions, their ability to complete tasks, literally physically, can be impacted by this. So it affects many aspects of their body and their functioning and their life. It is not just one area. It's not just in the workplace. It really impacts social, occupational, educational, health, personal relationships. If we look at suicide specifically by the numbers, the World Health Organization estimates there's about 800,000 people a year that die by suicide. It's one death every 40 seconds. A little bit closer to home, in 2017, which is the last year that we have data from the CDC, we lost over 47,000 Americans to suicide. And just to give you some perspective, that is more than the number of people that died by breast cancer. That is more than the number of people that died by car accidents, HIV and AIDS, and DWIs. And turns out to be about one death every 11 minutes. When it comes to suicide attempts, and deaths, males tend to die more often than do females, and that's true pretty much around everywhere in the world except for a couple countries. But males die 4 times as often. Females attempt more frequently. Now we're starting to see a change in that over the last decade, where we're seeing more females make more lethal suicide attempts. And yet we know that there are an estimated 25 suicide attempts for every death by suicide. The ways in which people die by suicide in this country, about half, just over half, are by firearms. The second leading method of death is suffocation or hanging. Poisoning and overdosing would be the third. And then, as you can see on that slide, other manners of death are fairly small. These are cutting, jumping, falls, driving into solid objects. The majority of people in this country that die by suicide, again, it's by firearms, hanging, and by poisoning. If we drill down a little bit to the impact of suicide in the workplace, the census looked at deaths, and there were 275 suicides in 2017 in the workplace. This is fairly consistent with a rise in suicide numbers that we've had for the last decade in this country, and there are a number of media stories over the last 3 to 5 years talking about the gradual increases. It's important to know that there's not an epidemic of suicide. There's never been an epidemic of suicide anywhere in the world, and no epidemiologist will tell us that. It's the media that tells us that there's an epidemic, and that makes things very sensationalized, but it isn't real. And yet we still do know that there has been a very gradual increase over the last decade in really all age groups and all demographics. I'm going to skip to the bottom bullet there first. The major occupational group with highest male suicide is in construction. And there is a program from Australia called the MATES program, Mates in Construction, that was designed to deal with that, and it's being adopted here in different construction companies in the United States. But that is that particular occupation group. Recently, early this year, this spring, there was a report that came out from the CDC noting that farmers actually had the highest rates occupationally. When they went back and readjusted and looked at their numbers again, they changed that. Farmers do have very high rates of suicide, but they're not the highest. The other occupation that many people often hear about having very high rates are dentists. And again, while dentists do have higher rates, physicians, and in particular female physicians, have the highest rates occupationally. Attorneys also have high rates of suicide, and what we're starting to see really since the recession in 2008 are people in business and finance having significantly higher rates of suicide. When a suicide death occurs, it can really throw a company into chaos. Many companies do not yet have policies or procedures. They don't have specific people identified to be able to address this. They struggle with what to do, not just for the family, but for those working with the person who died. There's issues around, for example, what should happen with the person's desk, with their belongings. How long should it remain there? Should there be memorials? Who in leadership should attend a memorial service? Is it mandatory that you would have a CEO go to a memorial? These are things that unless companies think about in advance when a tragedy like a suicide occurs, there is a lot that has to happen for companies to make these kinds of decisions. And this is why some new national guidelines have come out about suicide in the workplace, and why we've been working and developing a program to specifically address what do you do in advance to prevent a suicide, what do you do when there is someone at risk, and what do you do after? And we will get to that in this presentation. Just a bit more on the numbers for some grounding purposes. The impact of depression on the workplace is both economic and it is personal. Depression is the leading cause of disability in the world. Depression impacts your mood, it impacts you physically, it impacts you behaviorally. And when it comes to depression in the workplace, there's two primary ways in which we see impacts. Presenteeism is somebody who is depressed at work but not functioning optimally. Their performance might be down. Their quality of work might be down. Their ability to engage and be proactive and responsive appropriately might have changed. They may have withdrawn and not be a part of a team the way they used to be. And we see this change over time. It's not that somebody just wakes up one morning and comes to work and is now depressed. We see this gradual change. And what ends up happening in a workplace setting is that coworkers and managers start to adapt to the person's change in their behavior and their attitudes, and they start to compensate for that person. And they do this for long periods of time before something happens. So presenteeism is a problem when it comes to depression, and as is absenteeism. Absenteeism is not just about being absent from work, days away from work. Sometimes it's weeks, whether it's short-term disability or long-term disability, but it is consistent and sometimes inconsistent work patterns. Sometimes it is working parts of days and not other parts of days, and needing to adjust people's schedules as they're dealing with depression. 1 in 10 will struggle with depression, resulting in a tremendous economic cost of over $200 billion a year. Some of this is attributable to the direct costs of treatment and care that people need. Some of it is to the lost productivity or absenteeism, as I was just mentioning, and others are when somebody dies by suicide, and there are costs related to that for the company. Each year, depression affects somewhere between 14 and 20 million Americans, and it tends to affect people in the prime of their life. We do see young people that suffer with depression, and it impacts them at school. But we see this very significantly because of the large numbers of people in the working age that are at work. That makes those numbers very high. It is a leading cause of lost productivity, again, in the $44 billion to employers, 68 million days of work missed by employers. And research has found that absence, disability, lost productivity costs more than 4 times the cost of an employee medical treatment. We know that for every dollar that is spent on prevention, you save somewhere between $4 and $10 in later costs, either due to an employee's mental illness getting worse or tragically a suicide. The good news about any of this, if there is good news, there's cost savings that can come from being prepared and being responsive as a business, and knowing yourselves and for those that you work with that depression is a very treatable disease. It is not curable. We don't have a cure for the mental illnesses, but we can treat them, and we can treat them successfully to the place where people can return to normal functioning. More than 80% of those who seek treatment will show improvement, and that varies over time. Sometimes it is fairly immediate in the matter of weeks. Sometimes it is a little bit longer in terms of months, but we definitely can show improvement in mood and concentration, attention, and ability to function properly in about 80% of the cases. There's also a human cost to depression and mental health issues in the workplace. There's a cost, a connection between both mental health and productivity. If somebody has, for example, attention deficit disorder, and they can't focus enough to complete a project, that can impact not only their work, but the work of everybody else on a team. We have other illnesses where depression will slow someone down such that a project doesn't get completed on time, or you have somebody that has bipolar disorder and they may complete the project, they may complete it early, but the quality of the project will be diminished. We know that more days of work are lost, and there's work impairment that are caused by mental illnesses far greater than some other chronic health conditions, for example, arthritis, asthma, back pain, etc. We know that these illnesses are significant and severe, and there's lots of them. What many people don't know is that many mental illnesses have physical connections to them. For example, somebody with a heart disease or a heart condition might also be depressed. We know some people that live with chronic pain also are depressed. We know that some people that are depressed have headaches chronically, backaches and neck aches and stomach aches. So there is this connection between the physical and the mental and the workplace. Also, mental illnesses and substance abuse cost billions of dollars in indirect costs, so you keep adding on the cost to a business. What does mental illness look like at work? I described a few of these things, but just to give you some idea on some of the broader spectrum of mental illnesses. When it comes to depression, you might have someone who has difficulty making decisions. They lack interest in any of the activities that they used to participate in at work, whether it was engagement with other team members or just engagement overall as part of the company, support and pride in their company or their workplace, or their end product, whatever they're working on. You might have somebody that simply can't get up and is missing deadlines, is unable to complete tasks. They might be tired all of the time. They might have a depressed mood and talk about very negative, very pessimistic, very dark topics, and they might disengage and withdraw from people. When it comes to attention deficit disorder and hyperactivity disorder, we see lots of disorganization, irritability, inability to meet deadlines and manage workloads, problems following instructions, not just from supervisors, but also in between coworkers and other team members. Anxiety disorders are the predominant disorder in our country, whereas somewhere between 14 and 20 million adults will live with depression. We have approximately 50 million people that will live with an anxiety disorder in our country. Anxiety causes restlessness, irritability. It can cause fatigue. It can cause difficulty concentrating, over worrying, and employees might need constant reassurance about their performance in terms of whether or not they're completing tasks on time or in a way in which the management is looking for. Finally, bipolar disorder, or again, manic depression, is where someone has a manic phase or a hypomanic phase. So they have an elevated mood, they have an elevated activity level, which can cause distractions and inability to complete tasks because people start many tasks and don't complete them or only complete them part way. They may become very argumentative, very disruptive. They may not feel like they need a lot of sleep or eating. And they may feel as though they've done a great job on something because they feel really, really good about their work product and their work in the team, when in fact it really doesn't match with what the company is looking for. As opposed to when somebody is in a depression phase, as I mentioned a little bit earlier, somebody is very down, can be withdrawn, unhappy, and struggle to get things done. There are some work environment factors that affect the health and well-being of workers. And I'm going to mention these, and on the next slide that you're going to see, some of these are going to sound very much the same, and yet we see them very differently. A few work environment factors that affect how people do at work in terms of mental health, mental well-being, include job stress, the work demands, the control of their work, all of the things that are out of control for an employee. These are things that are just the demands of any job. Benefits, what benefits are available, if there are benefits available to them. Some companies have benefits for their regular full-time employees, but not for contractors or not for vendors, even though those vendors might be particularly connected to that company. And that can create stress and tension between employees and vendors. Job security, whether it's in a good or a difficult economy, if there are sunset types of projects where a company might take on a project, and when it's completed, those employees, if there's not another project, they're let go. Seasonal employees also have job security issues. The work culture, sometimes the work culture is very positive, focused on health and well-being. Sometimes the culture can be very negative and very filled with stigma and challenges for special populations. There's also perceived fairness and equality, whether that's around pay or promotions, job title, treatment around number of projects being assigned, how supervisors manage, all of those things impact the well-being of employees. And the quality of leadership and management. The more senior and experienced managers might do things very differently than an inexperienced manager. These are the kinds of things that affect someone's well-being at work. Now, I'm going to talk a little bit about why employees might not seek help from an employer, and this is where you see some overlap. There might be some negative stigma or fear of losing a job, being treated differently at work. We know that, for example, in the military, people will not seek out help for mental health because they're afraid that their units won't be willing to deploy with them. We see the same kinds of impacts at work. If somebody is working as part of a team and they're struggling with depression, they fear talking to their manager about it because they're afraid their manager will not give them another big project that comes up or a project that they're really interested in. So they may not seek help because of that. Access to resources. If an employer doesn't have insurance or benefits, they may not seek out help, even outside of work. There's a lack of awareness and education, and some of this fills into that corporate culture in terms of is this a culture built on well-being and health, or is it a culture that only is looking at the number of employees and the bottom line? And there's also personal embarrassment, difficulty admitting that there's a problem. These are things that keep employees from seeking out help. When the trouble is that we know suicide is prevented and we don't get people to seek out help. The World Health Organization has identified these 7 areas as areas that we have enough data on to tell us that they make a difference in terms of preventing suicide. The earlier we can identify somebody who might be at risk through the risks and the warning signs, the earlier we can get them into treatment, the more likely it is we can prevent a suicide. The more we can train health workers and those who are connected to people that are working to identify somebody who might be at risk, we can reduce suicide. We know, for example, some of these other things, follow-up care. So when somebody has been identified at risk, they get help. And if we follow up with them, if we check in on them, and how we do checking in behaviors is important after somebody returns to work and reintegrates, those kinds of things reduce the risk of a suicide. Restricting access to means of suicide, in particular lethal means of suicide. This is environmental safety. And we're not talking about just in hospital settings, but companies where somebody might have a place that somebody could jump from, where there's sharps that are available, sharp objects like a box cutter, or medications that could be overdosed on. These are the kinds of environmental safety things that we need to take into consideration. How media reports on suicide affects contagion, alcohol policies, and technology-based solutions to be able to help monitor people who are at risk. We now know how it does make a difference. A few other things that we know about suicide. Suicide is incredibly complex and it's always multifaceted. There's never one reason that somebody would die by suicide. Again, we hear that in the media. For example, somebody might die by suicide because of a breakup of a relationship or a bad performance review, or they didn't get the raise that they were looking for. We know that that's too simplistic. There's always multiple things that go into every suicide. And the data tells us from around the world that 90% of the people that die by suicide have a psychiatric illness at the time of their death. So we know, and that may be undiagnosed, might be misdiagnosed, but the reality is that if we think of a mental illness as a floor, and there's other problems that happen in people's lives as stairs go up, we know that you get to a place of hopelessness and despair, and then we see people who are at risk of suicide. There are many factors that help us identify someone who might be at higher risk. For example, if somebody has a family history of mental health issues or a family history of suicide, they're at greater risk of suicide. Things in the environment, again, those high stress kinds of positions can increase somebody's risk. If somebody has a physical illness, either something that's come on and it's very serious or something that's a chronic illness, again, those can increase your risk of suicidal thinking and suicidal death. A lack of access to care, and in particular good quality care, also increases someone's risk. We know that when somebody can't get access to medical care or mental health care or substance abuse care, we know that their risk is higher because those untreated illnesses can lead to death. Isolation and being separated from people is another risk factor. We know that the more connections people have, the less likely they are to die by suicide. And of course, you see some of those other factors that could increase your risk, whether it's age, gender, sexual orientation, culture, and religion. All of these things increases someone's risk of suicide. Another thing we know about suicide is that talking about suicide doesn't increase the risk of suicide. And this is one of those awareness pieces that many in our communities don't know. They fear that if they talk about suicide, or if they ask someone if they're at risk of suicide, or they've been thinking about suicide, that person might go and do it. And we actually have a wealth of data that tells us not only does that not increase their risk, it actually decreases their risk, and it reduces their level of anxiety. So we know that talking about suicide doesn't necessarily increase someone's risk. It gives them a chance to feel less disconnected, more connected, and more understood. We also know that if we can recognize the early warning signs of suicide, we can prevent suicide. I briefly went through some of the risk factors. We also have protective factors. Protective factors are those kinds of things that prevent a suicide, that provide barriers and buffers for someone. But warning signs are those things that are telling us if somebody is at more imminent risk of suicide. Talking about suicide or in any way communicating someone's intent to die is something that we want people to pay attention to as a warning sign, not necessarily as a risk factor. And most often people don't communicate this directly. They don't say, I'm going to go kill myself tomorrow at 3 p.m. at this location and do this. Most of the time it's far more disguised. It's more something like, my team would be better off without me, or I'm just a burden to everybody here at the company. And we don't see those as a warning sign of suicide. We have to put it together as a piece of a puzzle. But communicating someone's intent to die, or talking about feeling hopeless, having no purpose or no reason to be alive any longer, or having somebody talked about feeling trapped, we see as a warning sign. One thing I can tell you about the last piece on that bullet point is that a good majority of the people who die by suicide will talk about being in unbearable pain. And they actually use those words. So if we come out of today with anything, I would say that if you hear somebody talking about being in unbearable pain, you want to take that as a very significant and serious warning sign of suicide. There's also behavioral changes, whether somebody is behaving very reckless or out of character, when their sleep is off. And in particular, we know that many people don't sleep the day or two before a death by suicide. So if sleep is off, if they withdraw and pull away from things that they normally were interactive with, whether it's a softball team at work that they used to be on, or going out to lunch every Friday, if they withdraw and they isolate, they don't participate, that's another warning sign to pay attention to. Obviously, looking for a way to die, whether it's by purchasing a firearm or storing up medications, if that's known, or if somebody's looking around a workplace for some place that they could hurt themselves, that would be another significant warning sign to pay attention to. We also have mood changes that take place as somebody gets closer and closer to death, showing rage or extreme irritability, extreme mood swings, and acting very anxious and agitated. Most people that die by suicide become very, very anxious and restless prior to their death. They pace, they can't sit still, their hands and legs are shaking, because we're hardwired to live, not hardwired to in any way to be able to take our own lives. A few more things about what we know about suicide. The protective factors are those things that reduce the risk that somebody might die. These are the buffers that help keep somebody safe. I mentioned being connected. The more connected anybody is to faith, family, community, workplace, any sense of belonging or a need to be a part of something, a group, whether that's connected to a small group or a large group, and sometimes it's a connection to a pet. Those things help reduce your risk of suicide. Positive life skills, problem solving, communication skills, coping skills, conflict resolution skills, ability to adapt and change, those resiliency kinds of factors, how you adapt and get through adversity. Those things make a very big difference in your protective factors. And obviously good access to care makes a difference. We know that treatment also works, and simply being able to communicate to somebody who might be struggling with depression or anxiety that there is treatment available, that it does work, that it does make a difference, and the sooner you get that treatment, the less likely it is to become very significant or severe and impact multiple areas of your life. So communication of a message that treatment is available and it works is much better. And there's many forms of treatment. Not just hospitalization as many people fear. There's all kinds of treatments that are available to people. Now, I'm going to shift here to suicide prevention in the workplace very specifically. What we know is that leadership buy-in to this is critical for success. There's a handful, two handfuls of evidence-based programs. Evidence-based programs meet the highest level of statistical scrutiny in terms of effectiveness. There's only a handful of these programs in our country, and the one that is most often referred to when it comes to suicide prevention is the Air Force model for suicide prevention, which was instituted many years ago. The reason that it was so successful at not only reducing the death by suicide, but also many other factors, DWIs, domestic violence, substance abuse issues, criminal acts, all of these things were sub-things that came out of enacting suicide prevention activities, was the leadership buy-in. It was adopted by the top person in the Air Force and throughout the Air Force, all the way down to people that were janitors and street sweepers throughout the entire service. What we know about the Air Force model and the other couple of models that have worked around the world is that when you have leadership buy-in, it works, and when everything changes or there's something that stops that leadership buy-in, it's not sustained. And that is, in fact, what happened within the Air Force as well. So we know that leadership buy-in is critically important. It demonstrates that the leaders value health and well-being, not just of themselves, but of their employees and the people that work for them as important resources to the company. The leaders we know want employees and we want them to be well, but if they demonstrate that through a suicide prevention program and a mental health and awareness program, that makes a difference. If they commit to making suicide prevention a company priority, that seems to make a difference. And if they commit to creating and maintaining a very safe and open conversation, culture, environment in which people can express whether or not they're struggling with a mental health issue, that makes a difference in terms of success. Creating this culture of acceptance and caring in the workplace fosters a safe and healthy workforce, and it actually improves success of a company. There's some different kinds of activities that can be done, whether it's around training employees on how to spot and identify stigma or challenge misconceptions or myths around mental health issues. For example, a myth is that if somebody's suicidal, there's nothing you can do to stop them. They're going to die by suicide. That's a myth. If somebody is struggling with depression, it's their fault. That's another myth. If we can raise awareness of these topics and train managers on how to recognize them and different ways that they can help adjust those messages, that makes a difference. Any kind of communication methods, whether it's posters in break rooms or it is staff meetings where messages can be presented that mental health is everyone's problem, it's everyone's concern, that mental illnesses are real, they're not made up, they're not false, they're not character deficiencies, they're not moral flaws, that makes a difference. That mental illnesses can be prevented and they can be treated. People can return to normal functioning and they can be managed to get people back to living the way that they want to. These kinds of messages throughout a company change the culture. We also know in terms of suicide prevention, I'm going to talk through now prevention, intervention, and postvention specifically around suicide in a workplace. We know that prevention is important to have proactive measures that a company can have in place to promote not just wellness, but to prevent a suicide. There's many activities that a company can take to do this, whether it's training leadership and management and all employees on important prevention topics such as basic mental health, basic suicide prevention 101, risk and protective factors, resiliency and how you cope with life's adversities. And these trainings that we do within companies, they vary. What training you give to senior leaders is very different than what training you give to managers, and that's very different than very general or basic training that you give to employees and coworkers on how to help coworkers. So when you adopt a training practice and you modify them for the different levels of employees, we see lots of prevention that makes a difference. We also know raising awareness and increasing the visibility of mental health and what services are available within and external to a company makes a difference. And that's because many employees simply don't want to talk to an EAP. They're afraid that that's going to get back to their supervisors. But if a company can identify community resources that are external to the company, national resources where somebody can call a lifeline or text line, that makes a difference in terms of the culture and prevention. We also know that policies and procedures for at-risk employees is critically important. We know that whether you're talking about a school or you're talking about a workplace or you're talking about for the federal government, the more policies and procedures we can have in place around what to do when somebody might be at risk of suicide, the better. We know that those policies enable companies to hold people accountable, but they also direct practices, and those practices really come into play when someone is at risk of suicide. Now, this is one of those very, very complicated issues, and not one that I can do in 5 minutes, let alone a couple of hours. But to give you a high-level overview of intervention, there's all kinds of things around training that can take place. and again, different levels of training for different people within a company on how to ask about suicide. There are certain ways to ask about it, what to listen for and how to listen, what the response might be to somebody who might be at risk of suicide, and how to follow up. You might remember early on I talked about that follow-up care after somebody's been identified at risk and reintegrating them to work. So we know that when it comes to intervention, when somebody's been identified or there might be somebody who's concerned about somebody else in the workplace, we can do lots of training on this. And this is a very different kind of plan than the prevention plan, which is raising awareness, getting people involved, changing the culture. This is, what do I do if somebody is at risk? We also take things far more specific and detailed on this. So when you're going to have a conversation with someone, who's involved with that conversation, how many people should be involved in that conversation, literally what is involved in where people sit, in what room those conversations have. For example, we would suggest that if you're meeting with an employee who might be at risk of suicide, that that person is not closest to the door. We would want somebody who's a supervisor or manager closest to the door. We'd want to make sure there's as minimal distractions in that room as possible. Obviously, nothing that could be used to harm someone. We'd want to make sure that people knew when that conversation was taking place and about how long it should take place. All of these kinds of things go into intervention. Now, sometimes interventions happen very, very quickly. Some are far more planned. And again, those policies that come in early inform those practices that are used in the intervention phases. We also have postvention, and postvention is a word that's not in the dictionary, but it is used in suicide as what happens after a suicide has occurred. Some people talk about grief and bereavement. In suicide, it's postvention. These are really split into two different components. One aspect of it is if there's a death by suicide, and one is about if there's an attempt or somebody who has been thinking about suicide that gets hospitalized and how you reintegrate them into the workplace. But having not only a policy around this, but practices and plans for how to operate after a suicide's occurred makes a big difference, in particular around reducing the risk of contagion. Contagion is a real phenomenon. It's a very small phenomenon. It's only about 1 to 3% of suicides. It is particularly sensitive for youth, and is largely around media and messaging about suicide. When it comes into play in the workplace is that if somebody dies by suicide and mixed messages go out to the workforce, or there might be somebody who feels very guilty or responsible for a last conversation with the person who died, and messages go out about that. This isn't particularly true when it's a manager involved with somebody who's died by suicide. We can start to see either a copycat effect or contagion, and we want to minimize that risk. So we want to develop plans after a suicide's occurred to deal with all communications and all messages that go out to the company, and there might be different levels of who gets what communication, and we want to have procedures around who gives those messages out. So it's not just about the timing, but about who's involved, and it's also about the content of those messages. And again, this is all about reducing the risk of contagion. We also know that after a suicide's occurred in the workplace, the first thing that we want to do is make sure that we allow for bereavement. We want a couple of weeks of time for people to grieve as the company continues to function, but then gets back to normal. And what we need to make sure is we communicate a message that we're not doing prevention work right away. And this is because many will ask, what did the company do? What didn't the company do? What did they know about this person who died? And what have we done about suicide in the workplace? And the message has to be communicated. We will get to that. We need to grieve first, but we'll need to get to that. But these are all things that go into postvention. The other piece is about making sure family is taken care of, coworkers most directly impacted, either if they saw it or they witnessed it or they found the person, that they're taken care of, and there's resources being supplied for those that are most impacted. When it comes to reintegration, this has to do with after somebody has either thought about suicide or voiced communication about suicide or attempted suicide, has left work for a period of time, and or been hospitalized and comes back to work, how do we bring them back into the workforce in a way that they don't feel that stigma and shame? They don't have employees feel like they're walking around on eggshells around the person that's coming back. What kinds of things can be communicated? What shouldn't be communicated? These are all many, many factors that go into thinking through a postvention plan. At SAVE, the organization that I run, we're addressing suicide in the workplace using this model that we will be rolling out in the first quarter. But this model is built on basically having a strategy to be prepared for any one of these instances. And we have a number of different program components, whether it is the policies, the procedures, communication messaging, and training that gets involved for companies at all different levels, depending on what the company needs and the size of the company. The process I'll go through in just a moment on the next slide, but the whole goal of a program model like this is obviously to make sure there's employee safety and well-being. That's really at the heart of all of this. But we also need to pay attention to mitigation of liability and risks and external factors. If you have a company and there's a very public suicide, it happens in a public place, whether it's in a parking lot or it happens on a campus, and other people see it or the media become involved, we need to have policies and procedures that can respond to that to protect the company. And make sure that the culture remains very positive and obviously end up with cost savings for the company. Our model, when it again is released next quarter, will be online. It'll be a virtual program with training that'll be available, both training videos and on-site trainings. Companies will sign up. They will complete a self-assessment to look at all these different aspects of a company. They'll have we will score the self-assessment, have a technical assistance meeting with those companies. We'll develop an action plan with the company based on the company's priorities, and then we will recognize those companies that continue on with these processes. There's obviously benefits for this, obviously cost savings, employee savings, cultural things that we want to pay attention to and make sure that we mitigate those risks and keep a positive corporate culture. Part of the reason we've done this is not only because I do a lot of consulting for many large and small national and global companies and have been doing that for a long time, and we need to have a program that can be used on a much bigger scale than just one person. So we've been developing this program over the last about a year and a half, which aligns with the new national guidelines that were just released this month in October. These are the list of the 9 recommended practices for suicide prevention in the workplace. And as you can see, they not only align with the things that are in our program will go beyond these things, but these are the kinds of things, whether you're talking about that corporate leadership from the very beginning, the training to mitigating risk, all of these kinds of factors are the things that are in the new national standards that have come out for the workplace. So I'm going to end there. We have about 10 minutes, and I just want to, again, thank the sponsors for allowing me this opportunity, for Rick, and for all of you who are participating and listening. You have a critical role in the success and the safety for employees around this country and around the world in saving people's lives, sometimes when they may not know it, oftentimes in advance of that, and definitely being able to respond appropriately. And I hope that some of this broad overview of suicide prevention in the workplace has been helpful.
Wow, Dan, thank you so much. To digress, in our talks, I knew you would give a good overview of everything, but I had no idea that it would be so comprehensive. With the dozens of attendees that we have online, we really don't have any questions right off the bat now. For some of our organizations, what is the like in terms of kind of like best bang for your buck, so to speak, like what is the best first step for organizations to even think about implementing a culture that supports mental health and is concerned with suicide prevention? What is just like the very small first step that an organization can take, in your opinion?
Yep. That's a great question, and actually a fairly easy one. In May is Mental Health Awareness Month. In September 10th is World Suicide Prevention Day, and many companies do things throughout the month of September around suicide prevention. Having an awareness day for either of those months around the importance of mental health and suicide prevention can be done in break rooms. It can be done in lunch breaks, in a morning coffee break, posters that are around, resources that are available that can be downloaded for free and given out to employees on the various mental illnesses, giving out wristbands, talking about how I support mental health and mental well-being. A very simple, very easy way to do it around national days.
Yeah, by making it that visible. Yeah, that makes sense. We did have one question from the audience. For companies that have experienced suicide in the workplace, is there a common response of, quote, I wish we had, question mark, like, in hindsight, these organizations that have had a suicide, is there something that they're saying, I wish we had this in place, or I wish we had known this, or I wish we had done that, for example?
Usually it's I wish we had a policy in place. And the second thing is I wish we had training on how to identify somebody who is at risk. We know that tragically, most people who die by suicide do give off warning signs. They tend to be very disguised. They might give them off to one person and somebody else is different, and it's not put together as a puzzle. So the more training that people can get on just some basic suicide prevention 101 is often what companies wish that they would have had.
All right. Yeah, and I think for a lot of our attendees today, I think we just had their first introduction to telling signs and on worksite diagnosing conditions. So, Dan, thank you again so much. We really appreciate it here at Health Action Council. We really appreciate everybody that's on the line today. And I know you got to get going, so I'm going to launch our poll for those of you in our audience that would like to receive continuing education credits for this. I'm not 100% sure that I will receive HRCI credits for this particular webinar, but I have submitted for it. But again, Dan, thank you so much. We look forward to seeing your organization's work and the program that you're releasing next year. And to everybody else online, thanks for joining us today.
Thank you.